My name is Karen Curtis, and I am the founder and executive director of the Care Partner Project. We are located here in Chicago, Illinois, and but we are, an online resource for patients and families and clinicians. So we have people from all over the world contacting us, like you, and it's really a thrill to be with you. Our role is primarily to help patients and families feel comfortable navigating healthcare, which, as you know, can be very complicated. There is nothing in life that teaches us how to be a patient or how to support the healthcare and medical care for our loved ones. I think it's universal that all over the world, there's this sort of conventional wisdom that when your loved one needs a hospital stay, for example, or is going through a particularly difficult healthcare challenge, that we're there for them. We will drop everything to be bedside with a loved one in the hospital, for example. But once we're there, we have no idea what to actually do. We don't have any classes in any of our schools. Here in the United States, we have very active Girl Scouts and Boy Scouts where you can earn badges for accomplishing new skills. And not one of them is related to navigating healthcare. And of course, the language of healthcare is really foreign. And it's very hard to learn on the fly when you're operating in a world with a foreign language. So we have simple checklists that people can grab and go, written in very plain terms, to help them understand and navigate various aspects of healthcare, whether it's childbirth or managing a doctor's appointment or a hospital stay, surgery. We also have, as a result of COVID, we have checklists for how to support your loved one's care when you can't be there, when you simply can't be bedside. So we're trying very hard to help people feel informed, comfortable, and confident. They are very simple, written in very simple language. We try to write them at the American Medical Association has come out with guidelines that any patient education should be written at the 6th grade literacy level, but we shoot for more like the 4th grade literacy level, and that's on the advice of nurses. We have tested our content, our checklist content, in a whole host of hospitals, and we love the feedback that we get from nurses, and they're the first ones to say, keep it as simple as possible, short sentences. This is what you watch for. This is what you, these are the questions that you need to ask. This is what you can say, and this is what you can do. And frankly, we develop them with the eye towards what can family members do to help support nursing, because it's no secret that they're stretched, and that quality patient care often relies on very simple little details, and a lot of them. And there is no reason why patients' family members, for example, at bedside can't learn all of these small things that can help support good care, and take some of the burden off of nurses who can then attend to sort of the higher order thinking that they need to do because they've got patients that are sicker than ever. So I don't know. I hope that makes sense. We kind of look like we're training, so we're sort of a whole cadre of almost nursing assistants or uh, assistance to both the patients and to the staff. We have a task force of professional patient advocates who work with us on the development of new checklist content. And one of the things that when we last met in last fall, we said, okay, what do we want to tackle next? And this was a group of about 15, and they were of one voice that we need to provide checklists for care transitions, particularly care transitions from hospital to home or to nursing home or skilled nursing facility. Those times when things can get lost in the cracks. And at least in the United States, there is a huge initiative to help make sure that patients are not readmitted. Historically, we've had a pretty high readmission rate of 20%. And the focus is on making sure that when someone leaves the hospital, they have the kind of support to help make sure that they get the proper prescriptions, that the medications are administered properly and carefully and correctly, and that they get to their follow-up doctor's appointments and that their follow-up tests are done. And so that the transitions home really require it to be mindfully planned, for the details literally to be top of mind with someone to help the patient, because no patient is ever 100% when they leave the hospital. And it's nurses can't follow them home. So someone has to be engaged, informed, and on the job. And that's what we're doing with our checklist, because no family member is really ever prepared for that either. But lots of patients have family members that are ready, willing, and able. They just need to know what to do to make a difference. I came to this realization, frankly, the hard way. My dad was diagnosed with idiopathic pulmonary fibrosis, which, as you know, is a terminal disease unless you have the grace and the gift of a lung transplant. And we he was graced. He was one of the 1% who ever gets a second chance at life with a lung transplant. And he was at the very top transplant, heart and lung transplant facility in the United States. His surgery went really, really well. Um, he it was just a miracle, the entire experience. And unfortunately, he took a fall within just a few short weeks of being discharged. It's a 6-week recovery after the transplant, and I think he was about 2 weeks away from going home. And his he took a fall because he had been walking in the hallway for exercise and had been escorted to the bathroom. But and the nurse did tell him, "Look, wait for me to come back." But she couldn't respond, and he thought, "Okay, I'll just walk back to bed." But he took a fall and he hit his head, and you can understand why she couldn't get back to him. She was taking care of other patients, heart and lung transplant patients on that floor too. So, long story short, that he was put in horizontal traction until a neurologist could evaluate him just to make sure that he didn't have any, injuries from the fall. And the neurologist that was supposed to come within a couple of hours actually didn't show up for 57 hours. So he was in horizontal traction for over 2 days. And when the neurologist finally came, and it was a Sunday evening, and it was only because I absolutely became uh, so outraged. And I'm sorry to say that I took it out on the nurse at the nursing station. I was, you know, beside myself because I was worried about pneumonia setting up. And finally, he was cleared. There was nothing wrong with him, but he was in the ICU the next day with pneumonia. And when he was in the ICU, he picked up MRSA and cleared the MRSA, but then was infected with C. diff. And then because he was sedentary in ICU a lot, he ended up with a blood clot that actually DVT, then a blood clot that went to his new lung. And 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 the cycle was set up. He then contracted MRSA again, then C. diff came back, and in the end, he was in the hospital for 7 months, never left. And 7 months and one day after his transplant, he passed away from infection. And my sister and I were there nearly every day, and my mother was there every day. And um, and my sister is a nurse actually, but she had always worked in behavioral health, and that doesn't prepare us. I mean, she knew the language a little bit, actually a lot better than my mother or I, but still there were things that just kept happening, and we it was just devastating to lose him after the long fight to actually get along, and that actually did go so well, and he had the promise of a of life again. So in any event, afterwards, a few weeks later, my husband entered a different hospital for routine surgery and ended up with sepsis and nearly died. And when he was in the ICU there, he picked up vancomycin resistant enterococcus. He was really debilitated for about 18 months, but he did survive. Afterwards, um, you know, I'd have to say the grief and the guilt were really tremendous, thinking, how could I have been better prepared to be sort of that care partner that my dad and my husband really needed? What could I have done? I just felt terrible. Um, and so I thought, okay, let me figure out what happened. Let me figure out how I could possibly do something to help other families not have to go through this, not lose their loved ones, to all of these things that are entirely preventable. And I only learned that. I mean, I thought at first it was just bad luck, but then I realized after everything that I read that in the United States anyway, this happens and claims, almost 400,000 lives a year. And 1 in 3 patients have things that happen, things that fall through the cracks. And it made me realize that family members are so well intentioned. They want to be there, they want to help, and we can pitch in. We just need to know what to do. So I actually started by downloading nursing textbooks and just went on from there. One of the things I'm really proud of is that we have several community education programs where we have professional patient advocates who go out into the community and they speak with our programs that we have. And I have to say, we've had really great reviews of our programs because they're not long. They're kind of short, 30 to 40 minutes, but they're just packed with tips. And there's also an opportunity at the end for audience members to ask questions of these professional patient advocates. And the feedback that we've gotten is that people walk out with, new information and feeling really more confident, even though sometimes we're covering kind of topics they've never thought about before. They might find, kind of hard to deal with. It's, a lot of people really don't want to talk about, healthcare. It's hard to think about, your loved one being sick or you're being sick yourself. And, but the people and so that's why we try to make our presentations is like, they're serious, but they're delivered in such a friendly way. And we invite a lot of conversation. And it's just, so right now we're covering about 40 markets in the United States, but we're happy to bring other people in. I mean, the material is licensed, and I have to say it's a very nominal fee though, simply because all the content has been vetted by so many clinicians that we just really need to make sure that that the programs are delivered, as sort of a whole unit, because our name is on it. And I'm sure that's completely understandable, but we would love it if other people would like to take our programs into their local libraries and their community centers and their independent living. Those are the kinds of places that we go to. Professional organizations, like there are a lot of employee benefit groups that have brought our speakers in. Anywhere that people congregate. In the United States, we have Rotary Clubs, and they have monthly meetings, and I would have to say that we've pretty well covered the Rotary Clubs here. And it's as I said, it's just the feedback that we've received has just been so gratifying that it's a wonderful program. Yes. So, to actually see any of ours in action is, I'm hesitating a little bit because it's a little bit difficult. And I'll just give you the example of like Rotary Clubs. So we'll have speakers that are community libraries. We don't tape record them. And typically it's up to the library if they want to live stream it to their community. They handle it. We typically are not in a position to be able to invite, the outside world to watch our programs. Now, I have to say, I would be completely happy myself, and you're just giving me this idea. I hadn't thought about this before. It's like if there's any group that wants to have us come, by Zoom, just like we're talking today, we can certainly do that. I have to admit, I've been thinking, so maybe locally, here in the United States, where we've got the advocates are going out to local communities, really by Zoom for the last, 20 months or so. Now more often going out to live meetings. They're starting to open up again. Yes, our workshops, up until I would say we did our last hospital-based workshop in September of 2020, and it was on Zoom. And we decided to hold off on those for a while, in part because it was really hard for the hospital staff to spend the time. So our workshops are called Safe and Sound Family Engagement for um, Patient-Centered Care. And it's really a deep dive on how to use our tools for family engagement for um, uh, just as I said, for supporting quality care. The it's just our experience it was rough on them. And at the time, too, families were not being allowed in hospitals. So we still have the program. It can last anywhere from 3 hours to 5 hours, depending on, the teams internally. Or we can break it up into like 1 hour lunch and learns, which I think is probably more realistic given the given the current, climate. Wow, that is a good question, and it's a broad question. For example, we have a checklist on our website at thecarepartnerproject.org where uh, there are a couple of different checklists actually that are meant to work together for if you have a new diagnosis. You go in and the doctor says, okay, we think you have osteoporosis because we've just had this test. So that's a diagnosis. And the treatment will be usually the first thing that comes to mind with osteoporosis, for example, is medications. So we have a list of questions that you can follow to help make sure that you're getting the correct diagnosis for you, and that maybe going the medication route, is that the right thing for you to do, or perhaps you need to get a second opinion. So it's sort of a guided discussion, and you can take those with you, or you could read them beforehand. Ideally, it would be great to go to a doctor's appointment with a good friend who will have that list with them and help guide you through the checklist with the doctor, and take lots of notes for you. And then we have something similar, like when surgery is recommended. Surgery is a big deal and it's a big decision. Unless it's emergency, you have the time to really find out what it's all about and to get a second opinion. And I think a lot of people would agree that getting a second opinion on a surgery is pretty wise. There is really no such thing as routine surgery. There's risks in all surgery. So in any event, we have those things at thecarepartnerproject.org to help you get through that, because again, there are no classes in it, so we've tried to give you those quick checklists. I love that question. Yes. Here in the United States, it kind of sets doctors' hair on fire if you ask to record your conversations, because we have such a litigious culture. And so they worry about that. However, if you explain it, and this has happened, yes, I've done this myself, and I explain, this is how I explain it, is everything you're saying to me is really important. I can't keep up with you with my, chicken scratch handwriting. And I want to be able to listen to you. I want to have really good notes so that I can follow your instructions afterwards. And I will feel comfortable that I've mined every bit of good information out of this meeting as I possibly can. And then when you explain it that way, yes, certain people will still object, but if they understand it's really, it's just, their words are important, and you want to revisit them. And you can say, too, I learn best when I listen later. I would rather not take notes so that I can attend to everything you're saying now and listen later, because that's the way I learn best. So that's that, that's all very reasonable. And those are just a couple of tips, but just to sort of own your need to make sure that you're going to be, basically a good patient, that you want to comply with their advice, but you really need to have a record of it. Well, I would love to share that. The hardest thing about, having, sort of this online resource is just getting the word out that it's there. I have to admit, doing SEO for our website is kind of hard, because people don't, like, people don't Google how to manage a doctor's appointment. But if you've been through a few, you know that, gee, I walked out of that appointment and I really didn't understand what they were saying, or I wish I had asked. And so, of course, in our checklist of the Care Partner Project, we coach people on how to prepare for a doctor's appointment, kind of the supplies to bring, and the, how to, like, write down your questions in advance. And then we have like a little chart of a body that you can kind of fill in beforehand to show like where your pain is. Those kinds of tools help doctors really quickly get an idea of why you're there. And it helps to maximize the short amount of time that you have with them. If you go in prepared with some of this basic information, in any event, um, so nobody Googles that, right? So we don't, we're relying on all of you to help spread the word that we have these resources for patients and families. And then the other part of what we do is, there are a lot of people out there who are, who have no one to help them get through a healthcare crisis, or even to get access to regular health care. In the United States, we have a big homeless population. We have people um, who are alone and with no resources. So one of the other things that we do is we have a fund where we are able to cover the services for private patient advocates, for people who they meet, who as I said, who have nothing and no one. And so we're always on the hunt for funding for that program. We have made amazing uh, the stories that I could tell you about the people that have been helped by that program, um, is truly, I I just can't even tell you how blessed we are to be able to have this cadre of advocates that are willing to step up and to help people through our program. So, but we need funding for it. we we really do. I About 30% of the people we serve are homeless, um, and we want to continue. Um, oh, that was such a joy. I would often speak with my colleague Mary Foley, who is on the faculty of University of California, San Francisco, Um, she and I, uh, with another nurse who is on faculty at Northern Arizona University, we put together our hospital curriculum, safe and sound family engagement for um, patient-centered care. The three of us did this, but Mary and I spoke together. We're really a good tag team because she represents the nursing side of it, and I represent the family side of it, the family member care partner side of it. And we always use the word care partner deliberately because I think a lot of people refer to families as advocates, but there are professional advocates that do that work, and then there are advocates inside the hospital that also have an important role. But we see the family members as sort of the care partners to their loved ones, but also the care partners to the staff. So we deliberately use that because we're all about, what what can we possibly do to build teams, to build care teams that benefit from collaborating in very simple ways. So that's what Mary and I talk about a lot. And that's what we are striving to nurture, are these care teams. And so in any event, Mary is a lovely person and very well respected here in the United States. She's a former president of the American Nurses Association. And actually, she was the president of the Student Nurses Association when she was in nursing school, too. Yes. We're all adjusting to this world, right? And yes, very definitely. Yeah. We're just, it's a joy. It's just really a joy. I have to say, I love nurses. I do. Not just my sister and not just Mary, but I am just, in awe of what nurses do. And I, you know, in fact, most of the advocates who are doing our community education came out of nursing. So it's just a really wonderful, wonderful community of solid souls. Okay. Well, it was a pleasure working with you and thank you for your patience. Yes, you can find us at www.thecarepartnerproject.org. Yes. Thank you.